Welcome to Badger Talks Quick Picks, which brings exciting happenings, resources, and talent from your UW flagship campus to the people of Wisconsin and beyond, demonstrating the power of the Wisconsin idea, one connection at a time.
Welcome to today's edition of Badger Talks. I'm Marina Sharifi. I'm an assistant professor in the Department of Medicine and a breast cancer medical oncologist. And today I'll be talking to you about breakthroughs in personalized treatment for metastatic breast cancer. Breast cancer is the most common cancer in women in the United States as well as in Wisconsin. And 1 in 8 women will experience a breast cancer diagnosis in her lifetime. Breast cancer is also the second leading cause of cancer death in all women in the United States and the leading cause of cancer death in women aged 20 to 59. Breast cancer is a cancer that develops from the ducts or lobules of the breast. And there are actually 3 different types of breast cancer. And both the type of breast cancer as well as the stage at diagnosis determine what a woman's treatment options might be and what outcomes might look like. Honing in on the different types of breast cancer, those are determined by markers on the surface of the cancer cells that tell us what is feeding the cancer and causing it to grow. The most common type of breast cancer is hormone receptor positive or estrogen and progesterone positive breast cancer. And this accounts for about 75% of all breast cancer diagnoses. In these breast cancers, estrogen and progesterone receptors, markers on the surface of the cancer cell, allow the cancer to be stimulated by estrogen and progesterone, normal hormones in a woman's body. Treatment for hormone receptor positive breast cancer typically consists of oral anti-estrogen medications that block that estrogen signaling that allows the cancer cells to grow, as well as other types of targeted therapies. The second most common type of breast cancer is called HER2 positive breast cancer. In HER2 positive breast cancer, a different type of marker on the surface of the cancer cells allows the cancer cells to grow through a different mechanism. This also has a type of targeted therapy that we can use, antibody therapy, that allows us to block that growth mechanism and kill HER2 positive breast cancer cells. The least common type of breast cancer, and also the most aggressive type, is triple negative breast cancer. These are breast cancers where the cancer cells have no estrogen, progesterone, or HER2 markers on them. And so we don't have targeted therapy options that can help us treat the cancer. Triple negative cancers typically are treated with chemotherapy, although sometimes immunotherapy can also be effective. As I mentioned, the second most important thing after the type of breast cancer that determines a woman's treatment options and outcomes is the stage at which the cancer is diagnosed. Earlier stages mean that the cancer is less advanced in the body, perhaps only localized to the breast or the breast and the nearby lymph nodes, and is usually able to be cured with a combination of surgery, medical therapies, and radiation. Once a cancer spreads beyond the breast and local lymph nodes, it becomes what is called a stage 4 or metastatic breast cancer, meaning that those breast cancer cells have gone to other organs in the body like the lungs, the liver, the bone, or the brain. Unfortunately, at this point in the course of a cancer diagnosis, the cancer is no longer curable, although we do have many different types of treatment that can help slow down the cancer. And in fact, over 150,000 women in the US are living with metastatic breast cancer right now. And today I really want to focus on some of the advances that we've had in the treatment of stage 4 metastatic breast cancer and the ways that my lab is helping develop new tests to help us understand what the right treatment is for a specific woman. When we think about treatment for metastatic breast cancer, because it has spread throughout the body, the mainstay of treatment are medication-type approaches, things like chemotherapy, anti-estrogen pills, or antibody therapies that can go through the whole body and target cancer cells wherever they exist in the body. Recent advances have allowed us to become more and more precise about targeting specific changes in a specific woman's cancer to be most effective in terms of treatment. For instance, we know that some types of breast cancer have DNA changes or genetic mutations that are driving the cancer, and that can be targeted with pills that block that specific mutation's activity. So for example, patients can have inherited mutations in a gene called BRCA, where there's a specific pill that blocks the effect of that mutation and kills their cancer cells. In women with estrogen-driven cancers, it's quite common to have a mutation in a gene called PIK3CA, which turns on a protein in the cell that allows it to grow out of control and has a pill medication that can actually block that effect. And we know that patients who have estrogen-positive breast cancer can acquire a type of DNA mutation in the estrogen receptor itself that makes standard anti-estrogen medications ineffective. But we now have new pill therapies that can overcome those mutations and still be effective for those cancers. More recently, we've moved beyond targeting specific DNA changes to even being able to target cancer proteins that are on the surface of the cancer cells. Different types of therapies have been designed where part of the therapy is what's called an antibody that can recognize a target protein on the cancer cells. And that antibody is then linked to some type of toxic agent that can then be delivered directly to the cancer cells, sparing the rest of the body the side effects that we expect from traditional chemotherapies. So for example, new drugs that have been very effective for metastatic breast cancer include antibody drug conjugates, which are a type of targeted chemotherapy that relies on proteins on the surface of the cancer cells to selectively deliver chemotherapy to the cancer, as well as what are called radioligands, which are a similar concept but with radioactive molecules, and an even newer type of therapy where we're actually using cancer-specific proteins to activate the immune system so that a patient's own immune system can help them fight the cancer. But with all of these new therapies, we then face a new challenge in the clinic, which is how do we figure out which of these many therapies is the right treatment for a specific patient sitting in front of us? And this now requires us to test cancer cells for those protein markers or cancer DNA for the DNA changes or mutations I mentioned before we can start a new treatment to make sure that we're using the right approach for that patient's cancer. Traditionally, we did this using tissue biopsies, where a needle is used to take a sample from a patient's cancer that could be in the liver or the bone. And this is how we've done this for many years. It's something that allows us to get a large amount of the cancer cells to look for DNA mutations or protein markers that can allow us to pick the right treatment. But it's an invasive procedure, and many patients actually don't have a spot of cancer that's accessible for a needle biopsy. That led to the development of a newer approach called liquid or blood-based biopsies, where we can actually sample cancer DNA from the blood of a patient with metastatic breast cancer. We've known for many years that when you have a metastatic breast cancer in your body, DNA from that cancer gets shed into the blood and actually can be recovered from a simple blood draw. Unlike a needle biopsy, this means that we can use just a regular blood draw, something that our cancer patients routinely do multiple times a month, in order to be able to take a sample of the cancer DNA. But traditionally, liquid biopsies have only been able to recover a small amount of DNA from the blood, and can really only look for DNA mutations, not the types of protein markers that are targeted by some of our newer therapies. And so my lab asked, could we use the DNA from cancer in the blood to detect more than just cancer DNA mutations? And in order to do that, we need to understand how DNA is structured in the cell and how that gets turned into proteins. So we can think about DNA as a template containing all of the genes in a cell. And that gets turned into RNA, which is a messenger that can activate a specific gene, that then gets turned into a protein, which executes a specific function in the cell. So in order for a cancer cell to make a specific protein, it needs to go to that section of the DNA, make the messenger RNA, make protein from that RNA, and then the protein can execute the function of that gene. And what we know about the structure of DNA in both cancer and normal cells is that genes that are not active, meaning that they're not making a protein that has a function, exist in a closed structure inside the cell. Whereas genes that are active, meaning that the protein from that gene is being made and the function of that gene is turned on, exist in an open DNA structure, which allows the RNA to be made from the DNA that can then be turned into the protein. And we can actually take advantage of that to use the cancer DNA in the blood from patients with metastatic breast cancer to understand which proteins are being made by a cancer cell at a specific time. And the way that we can do that is that when cancer cells release their DNA into the blood, that DNA actually gets cut up into small pieces by what are called enzymes in the blood. And so when the cancer DNA is closed, meaning that it's not making protein, those fragments are all the same size. Whereas when the DNA is open, meaning that that protein is being made, the fragments end up being different sizes because there's bigger gaps between the molecules that protect the DNA. And so we can actually take a sample of cancer DNA from the blood of a patient, and we can look at the pattern of fragment sizes to see if they're all the same or if they're all different sizes. And we can trace that back to whatever gene it came from. And that tells us whether that gene was making protein or not. And so as you can see here, we're looking at fragment sizes of the estrogen receptor gene in the blood of patients with metastatic breast cancer, where the samples on the left in red are from cancers that are making the estrogen protein, and so the fragment sizes are more variable, whereas the samples on the right in blue are from cancers that are not making the estrogen protein, and so we see less variability. And so we can actually apply this approach to understand whether the estrogen protein is on or off for a specific patient from a simple blood draw. And we're now doing a study funded by the Wisconsin Partnership Program, testing whether we can use this type of approach to personalize anti-estrogen treatment for patients with estrogen-positive metastatic breast cancer. And we can also then use this approach to look at other proteins that have specific targets, like those antibody-drug conjugates or radioligand therapies that I mentioned. And so in conclusion, breast cancer is the most common cancer in US women, including in Wisconsin. Treatment advances have led to multiple new targeted or personalized therapy options for treating metastatic breast cancer. But that's created a need for better approaches to understand the DNA and protein changes that are present in a specific patient's cancer, where currently a needle biopsy is required to determine the best treatment approach. We have developed liquid biopsy approaches analyzing cancer DNA from the blood that can be used to replace the needle biopsy approach to personalize treatment through an understanding of both cancer DNA mutations and also gene and protein activity, and in the future may minimize the need for needle biopsies. Thanks for your time today, and thank you for watching Badger Talks.